Hello, everyone. I'm Ron Waxman. This is the COVID-19 series interviews one-on-one at CRT Online. And today I have the pleasure to have a discussion with Dr. Jeff Dubin, the Chief Medical Officer of the MedStar Washington Hospital Center in Washington, D.C., our national capital. Welcome, Jeff.
Welcome, Ron. Thanks for the opportunity to speak for you and the audience.
Thank you. And today we are June 11th, probably going to post this on June 12th, 2020. And we are started to have elective, a little bit ease on some of the hold-up that were done before. Can you give us a little bit short overview? Where are we standing nowadays in terms of the hospital policies and preparedness for moving to the elective cases and so forth?
Sure. Well, I can tell you that, this morning at our morning management meeting, looking at our COVID stats, everyone had a sign of a deep relief because, today we're more than a third below our maximum number of patients that we've had in the hospital or peak so far. So we feel that we're hopefully over the hump, but we know that there's going to be ebbs and flows of the number of COVID patients coming into the hospital, but we're certainly feeling better about our overall census being much lower, at least on the whole hospital, and at least our floor census are lower. So in terms of opening things up,
can I ask you one question about it? I was had a discussion with Jonathan Reiner a week ago, and he says that all the hospitals, the CCU, are that there is no room, everything is loaded. What is the situation in our hospital right now in terms of CCU beds?
So we've been trying to keep one of our strategies with how we're maintaining our strategic and life-saving services for non-COVID patients is to try to maintain a CCU that's open. We're a trauma and burn center here, so we try to maintain that open. And if you're a trauma center and a big stroke center, you're always going to wind up with neurosurgical cases that are coming in there too. So we wanted to make sure that we have cardiac surgery, cardiology, CCU, neurosurgical ICU, and burn and trauma always open. And because we know that we've had flooded with the other ICUs with our regular medical intensive care type patients, but it's really largely COVID patients. And they are taking the majority of our beds, probably 40% at peak times of our ICU beds here with COVID. So we've been fortunate. We started out with a large number of ICU beds, and we're able to surge up. We converted some of our intermediate care units to actually COVID ICU beds as we needed. But we have been able to maintain our operating rooms, our PACUs, our procedural areas. We have left them as is, whereas talking to colleagues in New York City, they made operating rooms ICUs, PACUs ICUs, cath labs, recovery areas ICUs. We've been fortunate that we have not had to pull the trigger on those, but we have had that within our surge plans if need be. So our CCU, while we have had some patients who, turned out that they had COVID on top of their cardiac problems, wound up there, we've mostly been trying to keep the CCUs, relatively free of the COVID patients.
But we have a capacity right now for non-COVID patients. That's
yes. No, we have a fair number. Well, overall capacity. The majority of our ICU is actually non-COVID patients right now, but the ICU has ranged from maybe 20-25% to as high as 40% of the ICU. I'd say about 35% of the ICU patients are COVID. And so as you're talking about ramping up your pent-up demand for elective surgeries and elective procedures, those that are going to go to the ICU. So for example, the TAVRs, typically they will go to the CCU overnight for close monitoring. Well, you got to make sure that you've got enough CCU beds for those.
Okay.
Your cardiac surgery patients, they'll be in the ICU for a while. You want to make sure that you've got beds for that. We've put a number of COVID patients on ECMO. And so that limits the total number of ECMO circuits that, we're limited by the total number of ECMO circuits we have. And you have to wonder, well, if a patient from the cath lab needs to go on ECMO, do we in fact have enough circuits for those ones? So we have to weigh those decisions.
So one question about that a lot of people do ask, also patients and referrals. Suppose a patient needs to go to the ICU, let's say post-CABG, as you mentioned post-TAVR. Are they sharing the same room with COVID patients? I mean, how do you secure, or what do you assure them that in that room next to them not going to be a patient with a COVID patient?
Sure. Well, fortunately, we're not having to double up patients in our intensive care unit. If we did, we would only put them in a room with another patient if both patients were tested positive for COVID. So we do cohort COVID positive patients in double rooms on the floors. It's just all our ICUs. We don't need to be it. There is no way to be 100% sure that patients are not going to be in rooms next to each other that are COVID. And the reason I say there's no way is we know that some patients are asymptomatic, and then at some point they become symptomatic. So you could have a patient who comes in for an elective cardiac procedure, could be COVID negative on admission, but they could be slowly, festering the infection, and on day 5 or 6 turn positive. And then suddenly, they have COVID. You can't prevent that unless you have enough tests that you're testing every patient in the hospital every 4 or 5 days. And the reality is there are just not enough tests to test every patient that's coming in. What we are doing as much as possible is for any elective procedure, we're testing patients in advance, typically within 5 days of the day of procedure, whether it's surgery or interventional procedure, and then the patient has to self-quarantine. And if they're a patient that can't self-quarantine, for example, they have to go to hemodialysis 3 times a week, we will test them again the day of service to see if they're COVID positive or not. If they come up positive and that procedure is deemed that it can wait, we actually will cancel and reschedule them 30 days out and retest them. If it's a procedure that must go on because it just can't wait any longer, we'll go ahead and test them. We'll go ahead and do the surgery, and they'll be recovered in an area for COVID positive patients, and that everyone caring for them will know that they're COVID positive and take the appropriate precautions.
And why we have to take 3 days of quarantine? Today there are some rapid tests that, at least we hear that they can be done in 45 minutes. So do we have a shortage of those tests, or they're less reliable than the 3 days test?
Well, some of the tests are not as reliable as the PCR test. The other issue is there's a number of tests that are out there, and some of the more popular sounding rapid tests that are out there, they're rapid. It may take 15 minutes to run the test, but if you only have the ability to run one test every 15 minutes, and in a busy place you're doing over 100 procedures a day, there's not enough hours in the day to run all those tests. So that's what we're trying to do. Is the preferred is to do the test in advance, self-quarantine at home, and then we're really reserving those rapid tests for the patients that they couldn't self-quarantine for a valid reason, or even an emergency test. We're having patients who come through, whether it's a trauma or another urgency, and we don't have we can't even assess them. We're actually testing those patients intraoperatively, and so that we find out in the recovery phase whether or not we need to continue on COVID precautions or not. Because again, as you pointed out, we're trying to keep the patients that are known COVID, as far as away from the other patients as well. So we have cohorted wards. We have ICUs where we're trying to have 0 to few COVID patients, especially like our transplant population. We want to make sure that if they have to be in an ICU, they're sequestered far away from anyone who's COVID. So we're trying to take as much precautions as possible, realizing we just don't have the capacity to test everyone so frequently as we would ideally. So we're working around this, and we think we've been very successful in doing this, but we recognize that we cannot put every patient and every staff member just in a spacesuit to prevent them from catching anything.
During the pandemic, the past 3 months, you have physicians who were overwhelmed with a lot of work, and some of those that actually didn't have much work not because they didn't want to work, because they stopped the elective. So as the chief medical officer of such a big organization, how do you deal with that, make sure that you can distribute some of the load of the work, and what do you do with those who right at that moment, let's say GI, they couldn't do all their procedures, they could do still telehealth, but I can give other example. But how do you reconcile this, those who work on CCU, anesthesiologists working so hard and the others are actually less?
Right. It was challenging, I think, for, as you had said, like an intensivist is probably working very, very hard, and they may see the orthopedist who just does joint replacements, which have pretty much been on hold for the past few months, seemingly not doing a lot of work. It's all relative. We've got a great one-team experience here, and one of the nicest things, if there's positive things that are coming out of COVID, is the great teamwork that people have had. So we found that the greatest need for physicians to work with were on the floors taking care of the hospitalized patients on the floor level, as well as the ICUs. So we had cardiologists who were actually working, taking care of medical patients as hospitalists. We set up a satellite emergency department where we had cardiologists, neurologists, OBGYN doctors, surgeons, physiatrists, rehab medicine doctors, and a lot of these were medical subspecialists. So we had an oncologist, 40 years into his career, spending the day in our satellite ED taking care of walk-in patients. We gave them some backup, and we had some ED docs, floating through to sort of help them out on that. But people were able to sort of step up and fill in as they needed because they were available to do this. And we tried to match people as much as possible. So if we had a true crisis and we needed every physician available to work, we would have had the orthopedic surgeon or the urologist working to help take care of some internal medicine type patients on the floor with assistance. And they were willing to do that. I had an orthopedic surgeon, I would run into him every few weeks in the hospital, and he was like, "What can I do to help? I really want to help." And I said, "That's fantastic." I said, "Right now we're okay, but I've got your name on a list, and we'll call you as needed." Later, I ran into the echo lab. I wanted to look up, get a reading on someone, and one of the cardiologists who was reading echoes was telling me that, he really felt he was part of our one team here because he got to work as a hospitalist for a week, and he really felt that rewarded by doing that. Wouldn't want to do it every day. That he trained to be a cardiologist, but he felt that he was really helping take care of the COVID patients. So that was really a wonderful experience doing that. And I think people just have to understand that different specialties are called in to crisis work at different times. And so the orthopedic surgeon who is probably not working too hard for a few months, well, come a major catastrophe, that person's going to be coming in and they're going to be operating nonstop, setting bones if we have hurricanes or some other disaster that goes on. So, it comes and goes, and I think everyone is sort of doing their part. And if they're not able to put added work in, they're making sure that they're available and they're willing to help. And I think that's the best that we can ask for them.
Yeah, thank you. This is terrific to hear about it. There's another thing that I thought if I put my head in your role, there's a lot of confusion and mixed messages about therapies. We still hear the hydroxychloroquine controversy. Papers were pulled out from the New England and the Lancet. Then we have conflicting messages from WHO. Then we have data on remdesivir. Then we have more and more data that it's really not consistent. And as you, the chief medical officer, people look at guidance. I mean, what should we do now? I mean, should we give everybody hydroxychloroquine? Should we give those other drugs? I mean, what protocols should we use? I mean, how do you reconcile between all those mixed messages that's going and flying on a daily basis?
Well, one of the first things I learned early in my tenure as to be chief medical officer is to rely on your folks who have more knowledge than you on these topics. So I look towards our infectious disease and pharmacy experts on this. Fortunately, I'm part of a system. We have 9 acute care hospitals within MedStar, and so, but our infectious disease director here is actually our lead infectious disease doctor for the system, and so I'm able to contact him for any of these questions. And so we actually have a group of ID doctors and pharmacists, and we actually here, in terms of like sort of for the remdesivir, we actually have a critical care lead, or infectious disease lead, and a pharmacist lead that will look at all the requests for the limited amounts of the medication that we have, and we'll decide who needs to get it if we have to start rationing things out. As far as the hydroxychloroquine, as soon as there was evidence coming out that, hey, this is probably not the right way to go, we actually came out with some practice guidelines that changed and said, we're really not recommending this now. And we worked with our pharmacy to actually contact every physician who had patients currently on it that they had not taken it off once the system guidance came out to not do that, contacted them, and everyone agreed. And I think it's reaching out to people with the most up-to-date information that you have and sharing that with them, and then giving them an opportunity to ask questions and answer them to the best of your knowledge. That's how I think people are willing to go ahead with the guidelines. I think if you just call someone up and say, Dr. X, we're stopping your patient's, hydrochloroquine. Why? We're stopping it. Those are the rules. They're going to be very frustrated. But if you have a discussion with them and give them ability to talk about it, show them the evidence, everyone seems to go along with that. And as everyone also understands with this time of COVID is we've just been learning, month by month, week by week, day to day about this disease. And we know that we've started out recommending one thing and then may have changed a few weeks later or a few days later as we learn more information. And so people are willing to be flexible and agile and switching their care pathways as we learn more information.
You have seen a lot over the past 3 months and also therapies and patients, and you got a lot of reports. Was there anything that you felt that really works from all the armamentarium of therapies, protocols, that you can point out, this actually impressed me more than any other of the available?
So the number one thing is proning. So it's a really strange feeling to walk into an intensive care unit and look around and see almost every patient on a ventilator basically face down, prone on a bed. And they're like that for weeks. That was just bizarre. Every once in a while, pre-COVID, someone with severe lung disease, or maybe they have hemorrhage in a lung, or empyema or something, they're prone to increase their ventilatory capacity. But this is huge, and these patients were so sensitive that you go and you adjust an endotracheal tube on them, and they can be hypoxic for minutes to an hour or so after that because they just were in that right position. That's really, I think, been great. We've also found that the use of high-flow nasal cannula oxygen has helped put off intubation for patients, because we know once they get intubated, it actually their mortality goes up. And being able to people who were hypoxic, yet were able to talk to you and did not look like they had O2 saturations in the very low numbers that normally you're wondering how could they be alive, and they're able to tolerate it. And for those patients, rather than jump right to put them on a ventilator, just support them with as much oxygen as possible in a non-invasive way. That's really more so than any of the medications that are out there. The medications that are out there, we're hoping they work. They seem to be shortening the length of stay, but we haven't seen any magic bullet that you take this medication and you're home in 3 days and you have 100% chance of walking out of the hospital. We haven't found that one yet.
Yeah, that's terrific. And you mentioned before that we're seeing less patients as we started. The number of patients is dropping down. Do you feel also that the patients that are being admitted now are less sicker compared to those who came in March in terms of the intensity of the disease? Meaning that the intensity of the disease is not, obviously they have to meet a criteria to be admitted to the hospital, but is it fair to say that those patients that admitted today or last week are less sicker compared to those who were 3 months ago, or these are the same?
It's hard to tell. I haven't looked that detailed at the number of patients being admitted directly to the intensive care unit from our ED. My anecdotal sense is that it is lower. Our ICU capacity, our ICU patients are still, the COVID patients really haven't decreased very much, maybe 20% reduction, mostly because the length of stay is so long in the ICU. But I do have a small sense that there are fewer patients directly ED to ICU, so maybe we're seeing a little bit better. And maybe that means that the nursing homes where this has gone through and the elderly people in the area who have gotten it, maybe most of those people have gotten that hit already, and hopefully we're kind of in a downward trend and we're not going to see as many ICU new admissions. But I think we have to be, we've only been down for about 2 weeks. We really have to wait and see what happens again. And then, of course, as more people are going out and doing things, we all worry that, are we going to have another spike soon? And is that going to affect the people who are at most risk for getting illnesses? Perhaps the people with chronic heart and lung conditions have been staying home if they weren't in a nursing home. And what happens if they start venturing out? Are they going to be at more risk? So I think we have to wait and see. I am optimistic that that is going down, and I think until fall, I hope that we're going to be in better shape, but it's just too early to tell.
And maybe they have a less virus load compared to the patient at the beginning. I mean, they're still sick, but it's a question of the virus load, of the shedding less virus. I mean, just hard to measure it. But maybe the last 5 minutes, I'd like to focus on how do we go back to the new normal. I mean, obviously, you're running a very large hospital here, the largest in the national capital, and we really started to do the elective patients, but what is the strategy to accelerate returning to normal procedures in the hospital, if you can kind of summarize from your perspective?
Sure. So, we're not turning a light switch on because we can't. We still have a number of people staff that were redeployed. So the people who are working in an outpatient orthopedic or urology office, nurses were redeployed to actually work in other areas. So we're bringing those people back to staff. We're preparing the hospital to a new normal. So with the physical distancing, we have to make sure that our waiting rooms are not completely packed full of people. So we want to bring patients back, but we can't bring back the same number of patients who came every day, because our clinic waiting rooms will just be, people sitting right next to each other, and we can't do that right now. So we have to slowly do things. We have a pent-up demand for procedures, and we're trying to get through that. While we know that we're still having a number of COVID patients in the hospital taking up our beds, we're not ready to go back full steam ahead. So we're going slowly. We're focusing on patients who primarily can be done in the outpatient areas, or will only need a 1 or 2 night stay in the hospital and then be able to go home rather than waiting for a week in the hospital and then going to rehab, or patients who we know are going to need an intensive care unit bed, because we just don't have enough of those right now. And so we'll focus on as much outpatient procedures that need to be done in a hospital-based setting as much as possible, knowing that the patients who need bypass surgery and cardiac procedures and other cancer surgeries, they can't wait, and we're still going to accommodate those ones. But for the elective folks that truly can wait a little bit longer, we're going to have to wait, especially if those patients can't be done as an outpatient setting. And during this whole time, we're hoping that the numbers will continue to go down, and as we fill up more bed capacity, we'll be able to bring in more of those patients who we know are going to be in the hospital for several days at a time, and then we can get those procedures done. I think that, during this time, we know that telemedicine really expanded. Our system rapidly opened this up, and I think patients, for the most part, have embraced telemedicine. So that's going to be helpful in letting us be available to provide services to patients, both pre-procedure, routine visits, as well as post-procedural care, without having them come to the hospital. It's patient-centric, which is great for them. It can be very efficient for the physicians and APPs that are doing this. And it actually helps with social distancing by not having fewer patients coming to the hospital. So I think that's going to be, part of our success, is continuing to do some element of telemedicine. But, we know a lot of medicine is actually true physical touch, and we do need to bring those patients in.
We have a policy in the hospital that you have to walk with mask, no matter who you are, a physician, a visitor, a patient. I mean, it's very across the board, across the system. Do you think this is going to endure for a month, or this is something, do you have any plan? When would you decide to take this overhead mask policy, or to ease on that one?
I don't see this going away for quite a long time, Ron. Right. I think one of the things that we've learned, everyone's learned about COVID, is this asymptomatic transmission. We don't know what percentage of patients can get it, but certainly by having patients masked and having staff masked, it's going to decrease the chance that someone who's asymptomatic could actually spread this disease. And I think until there's a widespread vaccine, and then widespread acceptance of a vaccination, so we know that enough people have gotten this that there's some sort of herd immunity out there, I think we're going to have to keep masks on, keep the physical distancing, and recognize that this may be something that's with us for a number of years. And the last thing we want to do is, have someone spread it through an entire unit or more of a hospital and know that we could have actually done something to prevent it.
So this is like TSA after September 11th, right? I mean, you have to live with it.
Exactly. It's here to stay, but we can certainly learn how to work with it, make it more efficient, and this is something worldwide that people are just going to have to deal with. And if anything, hopefully this will help prevent having something like this happen again, because there's going to be other infectious diseases out there that are probably going to have a respiratory component of transmission. And if we're wearing masks, hopefully we'll all be better prepared and reduce our chance of getting the next bug.
Yeah, it's interesting. In my trips to Asia, I always was impressed how many people were wearing masks. I mean, irrespective to whether they had. So there is a culture that already has been adopted in part, this behavior. My last question, obviously a lot of people talking about a new surge at some point. Some predicted it's going to be worse than the first one. Some predicted it may be easier, but I think there is almost a consensus that there will be another wave of COVID-19. How is the hospital and you especially preparing for that, giving all the lessons that you had from the first experience?
Well, I think this has been, I wouldn't say a dry run because this has been a true run, but this has been a very good experience for the hospital to see that, we can handle this. And, we still identified additional areas we could surge up as we needed. I think the things that will help us for this is, number one, I think we're all masked and that we're sort of recognized that any patient, staff member, or visitor is at risk for transmitting something to someone else. So that will, put us on high alert and decrease the chances from spread within the hospital, which has always been a fear. We've gotten more and more testing available, and I hope that when the fall surge comes around, and I really do think we will have a fall surge, we're going to have a lot more readily available testing, because ideally we would test every patient coming in through the hospital with a rapid test, we hope, and so we know right then, so we can cohort patients who are COVID and keep the patients who are non-COVID separate. That will give us a heads up on this stuff. It's just like any other disease. The more I learn about, the more that the lay people learn about it. They know what disease is. I mean, we know that we don't want everyone to come to the hospital, when they have the flu or COVID until they have certain symptoms. And so I think that we can do that. I mean, but we're going to have more things. Look, we know that people are having clotting events from this. Now patients have strokes. You're going to test them for COVID as well. But we're really learning how to flex up. We're learning how we can redeploy physicians and other staff members as needed to do this. So, and we know that we need a lot of personal protective equipment, and people need to learn how to don and doff equipment. So I think that we're going to be in a better place. It's still going to be hard, and I think as we go into the winter months, as we know, when people are indoors, they're in close quarters with each other, it's just far easier for this disease to spread. And I think we just have to be very aware of that, be ready that we're going to have more patients coming in, be prepared, and make sure that we have low thresholds of testing people, and to do the right treatment that we know. We know that what works in the ICU, what doesn't. And for another example, we learned a lot of these patients are very fluid sensitive, and so we minimize the fluids on them, whereas normally you would give people lots and lots of fluid before putting them on medic vasopressors, and now it's the other way around. A little bit of fluid and a lot of vasopressor as needed. So lessons learned are going to only help us in the fall.
Terrific. I cannot tell you to thank you so much for all your time and the great work that you're doing here as the Chief Medical Officer at our system. I totally agree with you. Life has been changed. We're going to do more telehealth medicine, probably going to do more Zoom, although I'd like to meet you more in person. I mean, still in the hospital. But again, thank you very much for being available for this interview, and I'll see you in the wards soon, hopefully.
You will too. Take care. Bye-bye.